So let's move forward with today's clinical topic. Our speaker today is Dr. Christopher Resnik, a prosthodontist in private practice in Winter Park, Florida. He received his dental degree and specialty training at the University of Pittsburgh, and he's on the faculty of the Resnik Institute, which is the preeminent implant training group in the United States. Today, he's going to review one of the most important concepts in restorative dentistry, treatment planning, particularly for implant cases, and that is understanding restorative space. Dr. Resnik, it is all yours. Take it away.
Thank you, Dr. Park, for the introduction, and thank you, panel, for very insightful information. This afternoon, we're going to be talking about implant planning and understanding restorative space and its indications and implications in restorative dentistry. So with that, we'll jump right into it. We'll go over kind of our objectives for this webinar. We're first going to cover the complications when the restorative space or prosthetic space is violated, what can happen and what will happen. We're going to differentiate between a couple different terms used throughout the literature in describing the available space for our prosthesis. We will understand the different space requirements for different types of restorations. And then we'll also go over the different space requirements for our different prosthetic materials. We have many materials and type of restorations we can provide our patients when we're replacing their teeth. And each one of them is going to have its own kind of space requirement there. So we, at our institute, we've kind of come up with a flow chart that kind of differentiates between the material and the type of restoration and how much space is needed for it there. So if we start and jump into some of the complications, I'm sure Glidewell gets a fair share of cases that come their way where there's just not enough space or there's too much space from all the cases they get through their laboratory. But to kind of start with the complications, we have cases where we're going to have excessive space, so just too much space for the prosthesis. And then we have cases more commonly where we just don't have enough space for the restoration. At the end of the day, as Dr. Levine mentioned, implants are kind of voluntary. You know, people don't need implants, but the patients aren't actually coming to us for implants. They're coming to us for teeth. So it's our job as a clinician to ensure that at the end of the day, they're going to leave with a restoration that they're happy with. They don't really care at the end of the day how many implants they have, what brand implants they have. They just want their tooth back. So it's kind of our job as a clinician to ensure that we provide them a prosthesis that they're going to be happy with and is going to last them a long time. So if we start with some of the complications that we get with insufficient space, where we just don't have enough space for that restoration, one of the complications is going to be delamination, where the teeth are breaking off the prosthesis or the tie bases keep falling out of the prosthesis here. And that's just from inadequate restorative space for the prosthesis. We have chipped porcelain or acrylic. The patient on the right there presented in my office about a month ago. She had this all-on-X done that was done within the past 6 months, and she lost her front teeth there. It just broke off there. And as you can see there, there's just no space for the teeth there. Unfortunately, she has 6 implants already placed that are well integrated. She spent X number of dollars, and then she presents to me, and I have to be the bearer of bad news. We just don't have enough space for the teeth, and we need to do adjunctive treatment there. We have fractured prostheses. This is probably going to be the most common, where the prosthesis will break at kind of the weak link. With these full arch prosthetics, we need an adequate connector size to be able to support the conic spaces or spaces where we don't have an implant restoration. We also need sufficient material around our tie bases or whatever structure we have in there that's going to be supporting the prosthesis. Poor aesthetics. These are all cases that presented to my office for a evaluation after their implant treatment and prosthetic treatment were completed, and at the end of the day, they just weren't happy with what they were given. As I mentioned, patients are coming to us for their final restoration. They want their teeth back, whether it's a denture that's falling out, whether they have neglected their dentition and they want to kind of start over. But it's our job as a clinician to ensure that we have adequate space and kind of work backwards with top-down treatment plan, we like to call it, where we figure out where the teeth need to be and then we work backwards and figure out where the implants are. But these are all patients that presented to my office probably within the last year here, where we had to figure out what we can do to fix the situation. In some situations, we just can't do anything, and really the only way to do it is start over. screw loosening and fracture. The screw is going to be kind of one of the weak links within the prosthesis. If we have a patient that just doesn't have that much space and puts excess force, we're going to have much more incidence of screw loosening, or worse yet, fracture. And then you're going to have to retrieve these small prosthetic screws. Broken removable prosthetics, so patients that we're making overdentures for will break around the locator or kind of the weak link here. So we do need space for all type of restorations here, not just the full arch fixed restorations, but also our removable prosthetics, whether it's implant based or even just complete dentures. We need adequate space for that acrylic, the denture teeth with it. We also have complications with excessive space. So somebody that comes in and it's just going to be a huge prosthesis. We have increased force, which is going to translate not only to the restoration, but also the implant. So the longer cantilever we have from where that tooth is to where the implant is going to provide more or excess of force to that implant. It may cause us to actually change the restoration, where instead of doing a full arch zirconia restoration, we're going to be doing a removable prosthesis. With the zirconia restorations, we're limited by the puck size. So there's cases where the patient's restoration has to be actually bigger than that zirconia puck, and we're not able to make them a zirconia prosthesis. With it, we also have the weight of the prosthesis. So a lot of people talk about the weight of the zirconia. In my opinion, I think the weight of PFMs is actually even higher, but it is something that we need to take into consideration. If we have a prosthesis that's 20, 30 millimeters tall, that's going to be it's going to weigh a lot there. So it's something that we do need to take into consideration, and it may cause us to actually change our treatment or final restoration at the end of the day. So how much space do we need? You'll look in the literature and you see all of these numbers, or you'll hear people talk about it. Oh, you only need X number of millimeters. But what we kind of found from looking throughout the literature is there's no real conclusive or decision making. Everybody has their own kind of personal opinion, and they leave out a lot of variables. So throughout this, I'll be going through all the variables that we've taken into consideration that you need to as well when determining if you have adequate space there. So we have many different types of restorations that we can make the patient. And ideally, we're going to figure out what type of restoration we're going to make the patient prior to undergoing implant therapy or any surgical intervention there. So we must first understand the terminology. We're coming out with a new prosthetic textbook at the beginning of the year, and we did kind of a lit search on this. And there's many different terms throughout the implant literature as well as the prosthetic literature. So we kind of separated into talking about two arches at once or one arch here. So we have terms used in the literature that will correlate when talking about two arches, and those are going to be the interocclusal space distance, inner ridge distance, inner arch space here. Then we also have terms that we're talking about for just a single arch here. So the crown to height space or crown to implant ratio, restorative space, implant restorative volume, or prosthetic space. And what we kind of found was there, so if we go kind of into the two arches here, the inner arch distance is just going to be between the maxilla and mandibular dentate or edentulous arches. Interocclusal distance is going to be between the occluding surfaces. Then we have a rest position that we do take into account when we're dealing with vertical dimension or ensuring that we have adequate interocclusal space. And then the single arches, we have the restorative volume, crown height space, and prosthetic space here. And the two that we kind of focus on or are going to focus on are the restorative space and the prosthetic space. So these are the two terms that we're going to cover for the rest of the webinar here. And we have classification based on how each of these is going to differ here. So if we start here with the difference between restorative space and prosthetic space, they're not interchangeable terms here. So they both are calculated differently. And if we start here with prosthetic space, the prosthetic space is going to be a measurement from the patient's tissue to the occlusal plane, whether it's the incisal edge or occluding surface. So we're taking this measure on top of the tissue towards the occlusal plane. So whether you have a master model, you'll be taking it from the stone on the master model towards the incisal edge or occlusal plane, or you'll be taking it intraorally from the patient's soft tissue here. Indications are this is what we're going to be used for preoperative evaluation. So we'll mount a master model, and then you can kind of evaluate it here. Or on the right here, you can take a caliper and you can measure from the occlusal surface of the patient's denture tooth to the intaglio surface, and that'll correlate to our prosthetic space. Disadvantages of this measurement is post-operatively, we cannot modify the implant position. So we don't really get any information on the implant position with this, and we cannot modify it. Additionally, throughout the literature, we found that tissue changes significantly on patients. So whether they're inflamed or not, whether you're giving them local anesthesia and their tissue is blanching, whether they're smokers, we know with smokers, they go through a lot of tissue changes throughout the day, and you can see them one day and the next day, and it'll be a couple millimeters of difference here. So the other term that we're going to use to correlate the space from implants is called a restorative space. And that's done from the bone or the implant platform to the occlusal plane, so to the incisal edge or the occlusal surface here. So this is going to kind of take out the variable of the tissue there and go directly to that implant platform or the bone here with this. The benefit of this space measurement is we're able to modify the ridge. So if we're evaluating the restorative space prior to implant therapy, we're able to modify where that bone is on that ridge through alveoplasty or osteoplasty to create adequate restorative space here. We're also able to educate the patient and let them know, we need to remove a little bit of bone here to create space for our restoration, whether we're hiding the transition line, gaining adequate width for our implant position, or just getting enough space or for our final restoration. So we're also able to place the implant deeper. In doing so, sometimes we're going to have to change our prosthesis. So in a little bit, we'll go through the different prosthetic classifications that we talk about. And then post-operatively is where we're going to have to change our design here. So and we'll go through the different classifications with that here. So if we look at a pan here and we're trying to determine the space, how much space do we need? 10, 15, 20 millimeters? And how valuable is this two-dimensional pan here? The yellow line is kind of variable. Where do we put it when we're measuring for the occlusal or incisal edge for the maxilla and mandible? And we really don't get much information from a panoramic view here. So we have two different ways that we're evaluating space here. So when we're dealing with a dentate patient, we can look at mounted models here. So the case on the left here, we're going to do the prosthetic space from the patient's soft tissue to the opposing occlusal edges or incisal edges. On his CBCT, we're going to evaluate the restorative space by throwing in a virtual tooth. So all the CAD softwares out there for CBCT treatment planning, we're able to do a virtual wax up within there. And it's very easy as we generally have neighboring teeth through the dentate scan here. So we're able to position that implant at the necessary space to ensure that we have adequate restorative space. So this is just kind of a 3D view of going through a case on the DICOM software here, where you can see the virtual teeth in white here. And we're just looking at it from all axes here to ensure that we have proper emergence from the implant, as well as we have proper restorative space from that implant platform to the incisal edge, or even in this case, the cingulum, where that screw channel is going to be emerging from. When we deal with the dentulous, it gets a little more complicated here. So when we're dealing with prosthetic space, we use the patient's denture, make a wax rim, and mount our models. And then you can get a little roller out there and measure between the soft tissue of the master model to the opposing incisal edge or occlusal plane. That's going to give us our prosthetic space evaluation. But again, with that, we don't really get much on where the implant is. So, and we can't modify it. We can't just do cast surgery and then transfer it to the mouth there. So when we're dealing with the dentulous, generally, we're going to be looking at the restorative space evaluation for this. So we're looking at a 3D rendering of that implant in the patient's jawbone virtually, and we're positioning it in adequate place for the final restoration. But as you'll look at from that the right half of the screen there, we have two different positions of that implant there, and we don't know where the tooth is. So when we take a CBCT of the patient, we're just getting where their bone volume is. But when we're dealing with an edentulous patient, we have no representation of where the teeth are. And can't stress it enough, the patients are coming to us for their teeth. They want their teeth back, whether the denture is loose or they have terminal dentition. So we need to make sure that implant's emerging in the correct location, deliver them the restoration, as well as the correct location for that final restoration. So we do something that's called a dual scan technique here. My father wrote an article almost 10 years ago now in Dentistry Today that you can just type in on Google, and it walks through the step-by-step, but we'll also kind of go through it here. And what we do is we take a dual scan of the patient for it. So what this will do is when we're looking at that 3D view in the CBCT planning software, we're able to see where that patient's denture tooth is and work backwards. We call that top-down treatment planning, where we figure out where the tooth needs to be, and then we work backwards to where that implant needs to be here. So it's indicated for fully edentulous patients. They can be edentulous on one arch, they can be edentulous on both arches. It's the same technique here. But what we start with the dual scan is a well-fitting prosthesis. So when we're planning these edentulous cases, we want the teeth to be in the correct location because we're planning our implants there. So if a patient comes in with a denture where the teeth are all in poor location, roller coaster occlusion, or teeth are broken off, if we take a dual scan of that, we're going to be planning our implants where those teeth are. So we need to start with an ideal denture setup. We also need it to have intimate soft tissue contact, and we'll cover that in a little bit here. I then take a bite registration. So when we're dealing with reading a CBCT scan, when you have some overlap of the patient's dentition, you get a little scatter there. So I like having the patient bite gently into a bite registration. I like using clear registration because I'm able to see where that patient's biting. But generally, I just have them bite very gently until they can feel the material. When they can feel the material, they're not going to continue to occlude, which is going to create a little separation between the teeth, which just allows us to separate the teeth a little easier in the CAD software. We're then going to add these little markers, or they're called fiduciary markers, to the patient's prosthesis. So you can get them anywhere online. You can actually just get them on Amazon. I ordered them a couple of weeks ago on Amazon, but they're a little sticker that will stick to the denture, and in the middle is a radiopaque bead. So when we're taking our CBCT, we're going to get that little bead that's going to show up very clearly on the CBCT. It's going to be very small, uniform, round, and they make different sizes of it here. And any one will work there, but it's a little radiopaque bead. So we're going to add a couple stickers to the flange. Generally, I'll put 2 to 3 on the flange and then 3 to 4 on the palate here. So you just want them in different locations, because what we're trying to do is create enough points that when we take our CBCT, we're able to align the images together. We then insert the prosthesis in the patient's mouth with the radiopaque stickers on there, fiduciary markers. You'll then have the patient bite gently into that bite registration. And then we're going to take the CBCT of the patient wearing the denture with these stickers. We are then going to remove the patient from the CBCT unit. We're going to grab our glidewell box and we're going to place the prosthesis on top of the glidewell box. You can also use the foam inserts inside the glidewell box. They work very well. But we're now going to take a CBCT scan of the patient's denture. This is going to be of the patient's denture with the radiopaque beads or stickers on the prosthesis. If we're doing it on the top and bottom, so if the patient is edentulous on the top and bottom, we will end up taking 2 individual scans. So one of the upper denture, one of the lower denture, but it will be with these radiopaque beads. Depending on your CBCT scanner, some of them do want you to change the settings. I recommend contacting the person that you obtain your CBCT unit from, or look in the manual. They'll generally have different settings that you can choose, or reach out to your lab planning provider that's going to be making your surgical template or going through this, and they can help you out with the settings here. But these are just a couple of the settings that you should change for your denture when it is scanned here. So just to kind of go over that here again, the first scan is going to be the patient wearing the prosthesis with those radiopaque stickers, and the second or third scan is going to be of the prosthesis. The third scan would be if you're doing an upper and lower. We're then going to upload the scans to a planning software. So you'll upload the patient wearing the prosthesis. So that's going to be the one on the left. The one in the middle is going to be the one of the patient's denture. And what you'll notice are those real distinct white points on there are those radiopaque beads. And then what we would do is through best fit matching, a lot of the softwares will actually do this for you. Some of them will just have you select the dots and then they merge them together. The radiopaque beads show up very, very white and distinct. So at this point, we're uploading our scans to the planning software. So on the left there, step one is going to be where we upload the patient wearing the denture. So from that, we're just going to get the patient's jawbone, and then you can kind of see those little white dots in space. That's going to be the radiopaque beads on the patient's denture. The middle one is going to be the patient's denture with the radiopaque beads on. So that's going to be the one where we just take it of the patient's denture. And then in the planning software, when we merge the images together, we get on the right side there. So we're able to implement or connect that denture to the jawbone, and then we'll work backwards. So if we go through a little video here of one of my cases here, this is the patient without the denture in. So we're just scrolling through, looking at the bone volume, but we have no idea where the teeth need to be. So here I imported the dual scan here, and now I'm able to see an outline of where those teeth are there. So the green outline is the patient's actual tooth on the denture. And then from that, I'm going to measure from the incisal edge or occlusal surface back to the bone to get the necessary restorative space here. So this one in the anterior here, we need to bury it a little or do some alveoplasty to gain necessary space here. So this is a patient that has adequate bone that we need to place the implant deeper to gain adequate volume for the restoration. We're also able to add the multi-unit abutment on if we do need to change the angulation, because we're actually measuring from the platform of the multi-unit rather than the implant, because the multi-unit is going to add a couple millimeters depending on if it's angled or a straight multi-unit. So from this, we're able to kind of what we call top-down treatment planning and figure out where the teeth need to be and then work backwards. So that's the purpose of the dual scan here, is for planning the implants in a prosthetically driven position where the patient's final teeth need to be. So if we look at how much space is needed, as I mentioned, if you look in the literature, you'll find many articles that just throw these numbers around, but a lot of them don't talk about the variables, because not every patient is receiving the same restoration. Somebody may be receiving a 2-implant overdenture. The next person might be a bar overdenture. The next person might be a Bruxer 4-arch prosthesis. But are we going to have pink on that restoration, or is it going to be all white, meaning that we're just replacing their teeth here? So the literature is kind of all over the place where it doesn't go through each one of these variables. So we kind of came up with a structured classification here where we talk about all the variables that need to be considered when planning the implant here. So if we go through the variables here to start, are we giving them a fixed prosthesis or a removable prosthesis? What is the type of prosthesis? Is it going to be a bar overdenture? Is it going to be a locator overdenture? Are we replacing the pink when we're giving them the fixed restoration? Are we putting abutments on it? Are we going straight down to the implant level, or are we putting multi-unit abutments on? Locators, what type of attachment system are we using? What type of material is there? The majority of the cases are zirconia, but are we doing gold, porcelain fused to metal? Some people still do acrylic hybrids. Denture material, do we need to add metal mesh in there, or is it just going to be a denture? And then anterior and posterior, that's something that we also talk about. We have different space requirements in the anterior and the posterior. So if we go through the classification here and start with the type of prosthesis, we have a classification from MISH back in the 90s here, FP1, 2, 3, RP4, and 5. And just kind of a quick summary here with it. In FP1 is when we're just replacing the patient's tooth. So it's going to look just like their tooth when they had it. In FP2 is going to be where we're replacing the tooth, but it's going to be longer than what it once was. And in FP3 is where we're going to be replacing the gingiva as well. So the patient's lost some bone, or we need to remove some bone, or we're going to give them their tooth as well as their gingiva back. And then we have two different types of overdentures. We have a RP5, which is going to be a implant denture, but we're going to rely on the patient's stress-bearing areas. So we're going to keep the palate and the prosthesis on the maxilla, or we have an RP4. This is going to be where we generally do a bar, where it's going to be completely implant supported. And each one of these are going to have different space requirements. We also have prosthetic materials. We have many different types of restorations that you can do through the lab. We have people are still doing porcelain fused to metal. The majority of them now are zirconia, but are you veneering the zirconia? Is it monolithic? Some people are doing PMMAs, 3D printed, or even kind of the retrievable prosthetics. And there's many different types of prosthetics that we're delivering our patient here. Each one of them has its own space requirement that we need to think of prior to placing the dental implant. And then the location, this is something that we talk about a lot here. If we look at the average sizes of patients' teeth, the central incisors on average is 10.5 millimeters, but our molar is 7.5 millimeters. So why do we need the same space in the posterior that we do in the anterior? So that's something that we're going to take into consideration, because depending on where we're placing the implant is going to have a different space requirement. So here you can see kind of the anterior, the tooth is going to be longer, where in the posterior, it's going to be much shorter. So we don't need to remove as much bone in the posterior as we do in the anterior. So here, just kind of average measurements here of the centrals, canine, and molar position, because everything's going to be different here based on the averages. So our goal with this treatment is to determine the amount of space pre-treatment, post-operatively. We don't want to get the patient in for their final restoration and realize, oh crap, we don't have enough space. Now what do we do? It's very difficult to fix. So we want to figure this out prior to making the patient go through surgery, because if we figure this out beforehand, we can plan accordingly and reduce the amount of bone to create room for our final prosthesis. So if we go through the space required that we've come up here, we're going to start with fixed here. So if we look at the studies on fixed, as I've kind of harped on, the numbers are all over the place. Some will say as little as 7 millimeters, some will say as high as 15 millimeters. But these articles, they don't talk about the prosthesis type, the platform, whether we're going to the implant level or multi-unit level, what the material is. There's no consensus. So when we're dealing with a fixed restoration, we have many considerations that we're taking into consideration, whether it's screw retained, cement retained. The majority of our restorations, especially the full arch, are now screw retained just for retrievability. Implant level or abutment level, the majority of them we're using multi-unit abutments. We just know through the studies that it's better not to go down to that implant interface continuously, because that will induce bone loss. And then our material, are we doing PFM, acrylic hybrid, or zirconia? The Brux or zirconia is such a good material now, but people still out there are doing these acrylic hybrids, and they're going to require more space. So we came up with this chart here at the Institute where we have different space requirements here. So if we're dealing with an acrylic hybrid, so that's going to be a titanium substructure with denture acrylic layered on top of it. Our prosthesis space is going to be about 12 millimeters here. So that's going to be in the anterior and posterior. We need adequate space for the titanium substructure as well as layering on top. If we're evaluating down to our implant platform or the multi-unit platform, we're going to need 15 millimeters there. If we deal with our porcelain fused to metal or zirconia that's veneered, we're going to need about 10 millimeters in the anterior, 8 millimeters in the posterior, again, because our posterior teeth are going to be shorter there. So we don't need as much space. But if we look at the restorative space required, we're going to need about 11 to 13 millimeters of space here, because we have to think about the tissue there. So we're measuring from the implant platform, but we need space for the tissue there. So, and then if we look at zirconia, that's going to be our best material that we have in dentistry today. It's kind of revolutionized dentistry, and Glidewell has kind of been at the forefront of it here. But in the anterior, we need 10 millimeters. You'll hear people talk, you don't need 10 millimeters, you need 7, 8 millimeters. But if we look at the averages of the teeth, the average central incisor is 10.5 millimeters. So why would you only need 7 millimeters from the tissue? Because then the tooth's going to be 7 millimeters and it's going to look very small. So we need to go on the averages of what the literature shows us, and the average central incisor is 10.5 millimeters. So we need at least 10 millimeters in the anterior from that tissue level. If we're measuring down to the platform of the implant or the platform of the multi-unit abutment, we need 10 to 12 millimeters. We're going to need closer to 12 millimeters in the anterior, and in the posterior, we may be able to get away with 10 millimeters. So just go through a little example here. This is an acrylic hybrid here. So the reason we need more space for the acrylic hybrid is because we have the titanium bar structure, which needs to be at least 3 millimeters. And then we need adequate volume on top of that bar. We need the restoration for the tooth as well as the pink gingiva here. And then lastly, we need the space for the patient to clean underneath the bar. So a lot of people kind of forget about the tissue. We have our biologic width of 3 millimeters that is the reason why the difference between the restorative space and prosthetic space is that 3 millimeters. If we look at monolithic zirconia, this is kind of the best material we have in dentistry today for multiple reasons, which is kind of a full day lecture. But if we look at this case here, we need 10 millimeters in the anterior because that's the size of the central incisor. Whereas if you look in the posterior here, we only need 8 millimeters because you can notice from this image on how the tooth size goes a little smaller here. So here in the posterior, we don't need to replace the pink, where in the anterior, we do need to with the bone reduction there. So kind of to just summarize the fixed prosthesis here, the restorative space is based on our prosthesis material. The prosthetic space is going to be based on the tooth size being replaced here. In each of those carry its different space requirements. If we go into removable prosthetics here and look at it, we have kind of two different types of prostheses, whether we can make the patient, whether we're using independent attachments or we're doing bar attachments. If we start with the independent attachments, the literature is all over the place on the amount of sizes. We have anywhere from 7 millimeters of space required to 14 millimeters for these. And there's many variables. What type of attachment are we doing? What type of prosthesis are we making the patient? And there's really no consensus on this. So we'll kind of look at it in two different aspects here, whether we're talking about an RP4 and RP5. An RP5 is pretty much a denture that has implants. So it's still going to have the roof of the mouth covered, where an RP4 is going to be implant supported. It's still going to come out of the mouth, but it's not going to have the roof of the mouth here. Sometimes we'll even use a bar to support these. So we have two different types of overdenture restorations that we need to consider here. The one on the left is going to be completely implant supported, where we're not relying on that soft tissue to hold the prosthesis in. And on the right, we're using the stress-bearing areas of our conventional dentures to also support the restoration here. If we look at this slide, this is from Zest's website talking about the locator, where they say you can get away with 8.25 millimeters of distance, but they don't talk about really any of the variables. Are we in the anterior or posterior here? So if we look at this slide from their website, you need 2 millimeters of acrylic thickness to retain the metal housing. You need about 4.25 millimeters for the attachment and to allow some movement. And then you need 2 millimeters of thickness here. So they came up with 8.25, but one of the things that they forgot to talk about here is the denture tooth. They're just measuring from the acrylic. So this is great if we're not going to give the patient a denture tooth, but I don't know how happy they're going to be if you just make them a pink base plate that snaps into the locators. We need a denture tooth here. So we kind of came up with our own space requirements here, and we found that you need about 12 to 16 millimeters depending on a couple variables. A denture tooth is going to range from anywhere from 4 to 8 millimeters or even greater in the anterior. 2 millimeters is adequate to retain the metal housing. You do need a little more space to allow for the movement. I'll go through that a little bit more. And then the thickness of the soft tissue. Everywhere in the literature, we talk about 3 millimeter biologic width, but here we're only getting away with 2 millimeters here. So that doesn't really make sense. So if we kind of take a deeper dive into here and look at the space requirement, the attachment's about 1 millimeter thick, and then we need a millimeter of thickness for that. So that's about 2 millimeters. The tissue is 3 millimeters, but then we're coming up about 2.5, 3 millimeters. So that's why we need 4.5, 5 millimeters. Additionally, it's very rare for the tissue to be completely parallel. We're measuring from the deepest portion here because we need that locator to be above the tissue. So there's going to be instances where we're going to need more than that 4.5 millimeters. So that's why we kind of termed it 5. Here we're looking at the biologic width. We need 1 millimeter for the cellular depth, 1 millimeter for the junctional epithelium, and 1 millimeter for the connective tissue attachment. So, and that's kind of all throughout the periodontal literature on the biologic width here. And then the implant tooth. We need to figure out where the tooth's going to be. Ideally, that tooth is right over the locator attachment because that's going to direct all the force to that locator. A lot of times it's to the buccal, lingual, it can be apical or superior. So we need to kind of just protect ourselves because we can get the implant in the correct location, but there's certain times where that tooth isn't going to be directly over the implant. But if it is, we don't want to run to an instance where we don't have enough space for that tooth because at the end of the day, the patient's coming in for a tooth. So it's 8 to 9 millimeters if we don't want to put a denture tooth on there. But if the tooth needs to be over that locator attachment, now we're looking at 12 to 16 millimeters. So our kind of synopsis on this is for the prosthetic space, we need 10 millimeters in the anterior, 8 millimeters in the posterior. That's going to be measuring from the tissue there. We're not taking into consideration that biologic width. When we do go down to the implant platform, we're going from about 12 to 16 millimeters. Ball attachment is going to be a little more there, but the majority of the cases today we're doing with locators just due to the versatility and ease of use of them. We then have bar supported overdentures. So we have many different bar designs. The digital platform and being able to mill these has really created a endless options for these bar superstructures. It used to be where we would cast them on the upper left there where they cast O-rings, gold bars, but now everything's milled. The one on the bottom right is actually one of my recent ones where I did a zirconia bar. I was just testing it out and we're actually able to mill them out of zirconia now. So if we look at the space requirements, the literature, again, no consensus with it here, but we kind of just did the math here and changed it here. With a bar overdenture, on average, we're going to need about 15 to 19 millimeters of prosthesis space. Again, we do need to take into consideration that denture tooth on top. The bar is going to require more space coming out of the tissue than a independent attachment or a locator, and then we need to give it some room for movement there. One thing with the bars, there are endless variables. If we look at the bar locator, that's going to be kind of the easiest to use. One thing I don't like about the bar locator is it is a attachment that comes off the bar on the top. So it's going to require additional restorative and prosthetic space. So you can see from the bottom image there, the locator is on top of the bar. So we need adequate space for our bar. We need about 3 to 4 millimeters. We also need space under the bar for the patient to be able to cleanse it. And then you need the locator attachment as well as the locator abutment on top of it. So we need a lot of restorative space and prosthetic space for these bar overdentures. One attachment that I like using in my practice is a Bredent. It's an offset attachment. So this attachment does not go on top of the bar. It's actually on the side. So you don't need any additional restorative space or prosthetic space for it. And the way this works here is you have these little buttons that come on either the buccal or lingual that use a similar type of nylon type attachment that just snap into it. So it's good for compromised vertical. You still do need more restorative space than independent attachments, but it's a way that we can splint all the implants together, gain a little more stability and retention without compromising the vertical space here. So they do come in different retention levels, similar to a locator here. They're very easy to replace, but it's an offset attachment. They also have a friction attachment here where it snaps over top of it. So it's kind of a friction fit here for compromised vertical space here. So just kind of summarizing the space requirements for the bar different attachments here. With a bar and locator, we're going to need about 15 millimeters of prosthetic space. Again, that's going to be measured from the tissue level. If we look at the restorative space, we need to incorporate the biologic width in there. So we're going to need up to 19 millimeters of space for that. The Bredent, we're going to save about 2 to 3 millimeters of space with that. So that's one that we can get away with a little less space. And then the O-ring, that was kind of the old school method, or even the ERAs. You're going to need a little more space for that. One attachment that I've used in my practice is the conus attachment. This is an independent attachment that gives you the stability similar to a bar overdenture, but it's independent. It's non-resilient rigid, so it's going to function like a fixed prosthesis, but it's going to require a little less space. And the way this works is you'll take an implant level impression, and then the lab is going to make a customized abutment for your case here that will fit very, very snug with the male attachment within the denture here. So these are customized abutments that are meant to be parallel with one another here. So it's patient specific. So this is one of my cases here where we had, I think, 6 implants here. So the lab made these customized abutments that are parallel to one another. That's a seating jig on the upper right. And then you pick up the retention cap similar to you would a locator here. But for this, we're going to get away with a little less space here. And on the bottom right, what I'm showing there is it's completely implant supported. So I'm not relying on the soft tissue to support this restoration. It's going to function like a fixed prosthesis, but it's going to be removable by the patient here. Lastly, we do need to consider horizontal space. So, a lot of people only talk about the vertical space that we're going to need for our restoration, but we do need to think about the horizontal space. And I see this a lot where you'll get overdentures back here and the attachment is almost out of the denture here. These are cases where we need to overbulk the prosthesis to allow adequate material to retain that housing. If you're left with kind of the image on the bottom right here, you're just going to continuously break that prosthesis right around that housing here. So we do need to consider the horizontal space. All attachments will be different, but if we look at kind of the locator, which is going to be our most common one, we need adequate acrylic surrounding that housing. So you need 2 millimeters on the buccal and lingual. So we really need actually 9.45 millimeters of horizontal space to retain the locator housing. In instances where you do not have adequate space, I've used a micro ERA. So ERAs come in a couple different sizes. They have the traditional ERA, they have a partial denture ERA, and then they have a micro ERA. This is what I've used in cases where I just don't have the adequate horizontal space with it. So this is something that you can gain a little bit of space if needed for the horizontal. It'll function like a locator. It just won't give you as much retention here. So we covered a lot this morning / afternoon. So to kind of just conclude everything, our 2 main terms that we're going to use to talk about the space requirements for implant is going to be our restorative space and our prosthetic space. Restorative space is where we're going to be measuring from the platform of the implant or abutment to the final restoration, the incisal edge or occlusal plane. This we're going to be able to modify because we will either place the implant deeper or do alveoplasty when placing the implant. Our prosthetic space is going to be from the patient's tissue to the incisal edge or occlusal plane. This is not going to be modifiable. It's also going to fluctuate depending on patient's oral habits, social habits, accordingly here. Our goal with implant dentistry is to determine the space pre-treatment, not post-operatively. Again, the patient's coming to us for a restoration or their teeth. They don't care about the size of the implant, the brand of the implant. They just want their teeth back, whether it's 1 tooth, a full arch of teeth, they want their teeth back. Looking at the space requirement, there isn't a set number. You can't just say every single patient needs 10 millimeters. There's many, many variables that we talked about. So whether it's a fixed versus removable prosthesis, the type of prosthesis, is it going to be replacing the gingiva? Is it just replacing the teeth? Is it a 2 implant overdenture or is it a bar overdenture? The type of abutments, do we have multi-unit abutments on there? They're going to require a little additional space. The material, are we doing zirconia, acrylic hybrid? Is it denture material? And then the anterior and posterior. Again, the anterior tooth on average is 10.5 millimeters, but a posterior tooth may only be 6-7 millimeters. So we don't need as much plasty in the posterior as we do in the anterior there. Just kind of summarizing this, zirconia is going to be the most common material. We need about 10 to 12 millimeters of restorative space, depending on the area of the mouth. Independent attachments, we're going to be looking at the locator. We need actually 12 to 16 millimeters for restorative space. Again, we need to think about that tooth that we're replacing, not just putting pink acrylic around it. And then our bar overdentures. We have different types that we can use in situations when we don't have adequate space. And then lastly, the horizontal space, we do need to consider that when dealing with these independent attachments or bar attachments. We need adequate acrylic around it. And again, we want to determine preoperatively when we're doing our implant planning how much space we need. We don't want to have the patient come in for their final restoration and then we get the call from Glidewell that we don't have enough space. You don't want to just be opening their vertical and the articulator. We need to do this preoperatively before we put the patient into surgery and place the implants there. So thank you for having me here, Neil, and go through some questions.
That was an incredibly valuable presentation. I could hear all the screen captures going on when you just, not only did you summarize all the information and put it in an easily digestible form, but you kind of explained the rationale behind it. And for any of the people out there that have been in the position I've been, where you've just been in this case where, I had one where I just could not hide the transition line. I just,
Yeah.
there was too much bone left from the surgeon, and it's just a really really hard thing to recover from. So this is all about prevention, and you've given us the knowledge to understand it, to do that. So thank you so much, Christopher.
Yeah.
I've got some questions I want to jump into if you've got a couple more minutes.
Yeah.
uh, when you were explaining the dual scan technique, I got a question about using a digital scanner to scan the prosthesis. You do put a STL file of the existing prosthesis into the plan, or is that not necessary?
No, so you don't need that. You will need a intraoral impression of the patient's gingiva if you're going to be getting a guide. But what the dual scan is doing is it's capturing the thickness of the soft tissue. So the thickness of the tissue is going to be variable throughout the entire edentulous arch. So the reason we want the denture to be well fitting is because you want that entire intaglio surface of the denture to be contacting the tissue. Because what the dual scan will do is it's going to measure the height of the denture to the acrylic, and then it's going to overlay that on the CBCT unit and take into consideration the thickness of the tissue. So when we're planning our surgical templates, that's when you would need the additional information of the patient's intraoral scanning.
Excellent. Excellent. Very good. And I know there's a lot of great digital planning softwares out there, but somebody wanted to know which one you liked.
Yeah, I use RealGuide. It's a free software made by Zimmer. You can also use Blue Sky Bio. I have Anatomage at the office. So there's many out there. They all have their kind of bells and whistles. I kind of like a more simplified version. I like RealGuide. It's cheap. So I plan that at home on my laptop. But when I'm in the office, I use the one that comes with the CBCT software. They all have similar ways of implementing the dual scan. And if you reach out to their customer support or look on their kind of help support, they'll walk you through the steps. The majority of them are pretty cookie cutter, where it'll say import the patient scan, import dual scan, and then it kind of does it for you. But there's many out there.
Yeah,
But I
our
have the ones with
digital
bells
treatment
and whistles.
planning department is using RealGuide also. They found it to be a
Yeah.
really user-friendly, very good for communicating with doctors. So yeah, we'll put a good plug in for RealGuide. I got a question here about the Bredent attachments that you mentioned. So you talked about doing a milled bar in zirconia. Can you do a milled bar in zirconia and then attach the Bredent SG to it?
Yes, you can. So the milled bar and zirconia is something that I just kind of wanted to try out. I do have a titanium bar as a backup already for the patient, so if anything does happen, but kind of with the way everything's evolving, I just wanted to kind of see what the zirconia bar could do. So far, it's held up well, but I do have a backup there. But yes, you can do the Bredent attachment on top of it.
Got it. Got it. Okay, let me make sure I can give you this question accurately. So it's how many millimeters do you want your implant platform to be above the smile line for an FP3 prosthesis on MUAs?
Okay,
So
yes.
you got that.
Yes. So you want to be very careful with the transition line. So that is a nightmare, as you alluded to earlier. And what the transition line is when the patient smiles, it's what they're showing there. So what you don't want to do is have the patient smile and then they show their actual gingiva and then they show the artificial pink. It will be a nightmare for you and the patient. So what you want to do is make sure that the transition line, you hide it. So what that means is when the patient's at their exaggerated smile, they don't show any of their gingiva there. So, and you don't want it to just be at the level there. You need it to be at least 3 millimeters below, because we need the adequate thickness of the soft tissue. So you have to think about the biologic width there. So you want it to be at least 3 millimeters apical to the patient smiling. And when kind of taking that information, when the patient smiles, you want it to be the most exaggerated smile it can be. You don't want them to be given kind of a half smile. You want it to be like they just won the lottery. So, because you don't want them to come in and laugh one day and then they're showing it, because it's just a nightmare.
As Dr. Swanson says, smile like you never have to see me again. Just tell them
Yes,
that.
exactly. Like it's free.
Yeah, right. Excellent, excellent. All right, this one is not exactly on topic, but it's a great question. Zest has lecturers out there talking about immediate loading of implants with locators. Any thoughts about immediately loading locators for an overdenture?
Yes. So, yeah, and there are studies out there about immediately loading locators. What I don't like about it is the amount of post-operative appointments for the patient. So when you're placing implants on a patient, their gums are going to swell for 2 to 3 days and they're going to start to shrink down. And we know from kind of the literature or making immediate dentures, their gums are going to mature for 3 to 4 months there. So if you immediately load the implants that day, in 2 days, their gums are going to be swollen. So how is that denture going to snap into the locators? And then the gums are going to shrink. So at 2 weeks, the gums are going to be smaller than what it was the day of surgery. So now we're overloading the implants because it's going to act as a hinge and the implants are continuously taking the force. The reason the all on four, all on X works is because all the implants are connected together. So not one implant is taking the force there. By immediately loading locators, one may be taking it more than the other. The prosthesis may be hinging there. So I am not a fan of it. At the Institute, we don't teach the immediately loading of implants. Yes, things will work, but I caution you to kind of think about the rationale there. You don't need to be a hero in one day. Let the patient 3 to 4 months and then make their day there. So it's not worth kind of compromising the longevity of the implant just to try to, appease the patient or sell the case. So if you explain to the patient, if you get your knee replacement, you're not going to run a marathon the next day and kind of correlate it like that, patients are going to understand.
Great, great explanation, great rationale. Thank you so much. Okay, there's two questions that are kind of similar. Like, I've already got the problem. What do I do? So this doctor says, hey, a case came to the practice for restoration. Upper and lower implants are placed, and there's just not adequate restorative or prosthetic space. What would you do?
Yes.
Because
So
this happens all the time, right?
yeah. So what you don't want to do is throw the other dentist under the bus. So try not to say, the other dentist screwed up here. So if you didn't place the implants, one thing you do is reach out to the other dentist and kind of allow him to try to fix the situation. Let's say, you can change the restoration. So let's say it's in the posterior, you can do a metal restoration with it. You may have to do a removable prosthesis. So let's say the transition line's an issue. Explain to the patient, we don't have to put you through more surgery. We can just make you a removable prosthesis because now you're going to show all the artificial pink. So you can change from a fixed to a removable. Let's say it's worst case scenario, then educate the patient of kind of, in my hands, I can't do this. What I'd recommend is going back to the dentist that placed the implants and kind of talking to them about what they can do for you. What you don't want to do is tell the patient that you need to take the implants out, remove the implants, and now the other dentist is questioning you why you removed the implants because now you're in a sticky situation. So tread carefully, communicate with the other dentist there, and educate the patient as best as possible.
Yeah, and the other thing you don't want to do is jump in and start restoring a case that you know is not going to
No,
work.
yeah, exactly. Yeah. So
Exactly.
yes.
Okay, and the other similar kind of a question is this is a little bit less dramatic, but you've got a situation where a patient has an all on X and a tooth just keeps popping off. Any magic way to get it to stay in, and it's popping off obviously because the tooth has been ground down and there isn't really enough base acrylic to hold on to it.
Yes. So, and that's kind of the issue with the acrylic hybrids. So in my practice, I only do for zirconia. So you're dealing with a monolithic restoration. You're not dealing with anything chipping off. But let's say the acrylic just keeps breaking. What you can do is you can remove the prosthesis, send it to the lab, and they can relayer the entire prosthesis with acrylic. That would be new acrylic, and it would be kind of the full restoration. You can also do some alveoplasty or osteoplasty on the opposing arch to get a little more restorative volume in there. But nowadays, the zirconia, especially through Glidewell, is so economical and it looks so great. Really, I don't really see a need for doing acrylic hybrids. It's kind of all zirconia.
Yeah, there's a large implant DSO, and basically they do exactly what you said. If they face this problem, which they often do, they offer the patient an opportunity to upgrade to a monolithic zirconia prosthesis. And,
Yeah.
most of the time that's going to work.
Yeah. It'll just save you headaches in the long run.
There you go. Well, Christopher, this was just an excellent presentation. So well organized and so informative. I really appreciate it. I know everybody out there does. And thank you. And we'll look forward to having you back again real soon. Thanks everyone for joining us today. And be sure to join us next week when we'll have our business advisory panel as always. And our guest speaker will be Dr. George Schmidt. And he's going to take a deep dive into the workflow of the fixed hybrid all-on-X restoration. So we'll see you back same time next week. Thanks, panel. Thanks, Christopher. And thanks all of you out there for joining us. Take care.